Many mothers also fear. I have a PhD student, just to say, she's working with adolescent mothers, so teens that are pregnant. We're trying to prevent postpartum depression in these young girls because they're very high risk of developing postpartum depression. And she's finding when she's interacting with these teens that they don't go to antenatal care because they're afraid their child will be taken away at birth. Right? So this fear of having your child taken away is very, very common. Women are fearful of being labeled mentally ill, and they're fearful of not fulfilling the role as a mother. I was just in Doha, in Qatar. You might be saying, where is Doha? I asked that question too. It's in Qatar, and they're trying to promote perinatal mental health among Arabic mothers in Doha. And they're developing these programs in place, so I was going there and consulting them. And not fulfilling their mother's role is very important in that culture because that is their primary role. And so it's we can't underestimate, their perceptions that if I'm depressed, I'm not a good mother and I'm not fulfilling my primary role. For some women, depression implies weakness, perceived failure. Some family members may discourage help seeking for reasons that we already talked about, but some family members would encourage help seeking if they knew about postpartum depression themselves or their symptoms. Professional barriers, I think we're really working on this, but you will see in the qualitative studies that mothers will go to their family physician and say, I'm experiencing postpartum depression. And you say, oh, you'll feel better soon. That minimizing, the mother often feels angry after she's raised this and it's been minimized, and the chances of her raising it again is very low. So we have to really be aware of not to minimize when a mother discloses symptomatology. Also, limited training and assessment and management. Often you'll see that people don't want to assess for postpartum depression because if they identify it, what did they do with it? Where did they refer this mother? So we need to make sure that we have appropriate referral pathways in place for there to be proper case identification. And we also need to say that it takes time to assess a mother for postpartum depression. Research has shown that if we just leave healthcare professionals to identify postpartum depression in a very informal way, like how are you feeling, that greater than 50% of mothers with postpartum depression will remain undetected. Informal inquiry does not work. So that's why there has been a push towards screening programs for postpartum depression. There's two types of screening that you can implement. There's universal screening and there's targeted screening. Universal screening means all mothers are screened for postpartum depression, or we have targeted screening where only mothers that we perceive to be at risk for postpartum depression are screened. Of course, universal screening is more time consuming, more costly, but less mothers are missed. Targeted screening, we would be able to be more accurate in our screening, so we'd be spending less time on screening, but you are at risk of missing mothers. When would be the most effective time to screen for postpartum depression? There's been a really good review of the literature on antenatal screening where we look at all these different psychosocial factors, what we think places a mom at risk, and we now know that we cannot reliably identify mothers antenatally who are asymptomatic, so they have no symptoms of depression. We cannot reliably identify these mothers as to which ones will continue to go on to experience postpartum depression. So antenatal assessments of asymptomatic mothers leads to poor positive predictive validity of postpartum depression. But we can assess for mothers antenatally, but we assess for current depressive symptomatology and then provide the mother with treatment for the antenatal depression. But trying to identify mothers antenatally who do not have symptoms but risk factors does not lead to a really good identification rate. It's poor positive predictive validity. And that's just because risk factors are that. They're just risk factors. It doesn't mean for sure if you have this, you'll experience postpartum depression. So we recommend postnatal screening, and there's many points in contact with with mothers in the postpartum period that we can engage in these activities, or you can call it case identification. I know some people get stressed about screening, but you can call it case identification. And research has clearly examined diverse healthcare professionals can incorporate screening measures into their clinical day. We know that we can reliably assess for mothers in our clinical practice. There's no clear evidence to suggest when is the best time to screen. So my recommendation is that you would implement a screening assessment when you see the majority of mothers of the target population. So if you're seeing a lot of mothers at 2 weeks postpartum, then you can start assessing depressive symptomatology then. It's about integrating into your everyday clinical practice, not having to change your clinical practice to try and integrate this, because then the likelihood of screening will be decreased. Research suggests, however, that the majority of mothers will experience the postpartum depression within the first 12 weeks, so it's ideal to assess for mothers and their mental well-being in that first 12 weeks. What tools can be used to assess postpartum depression? There's multiple depression screening scales out there. The one that is used internationally, and I go to all the perinatal mental health conferences. I go to Marseille. I go to them every year. I know what people are using around the world, and it's the Edinburgh Postnatal Depression Scale. I know there's the Beck Depression Screening Scale by Cheryl Beck. It's 33 items, but you have to pay for it, and 33 items is a lot. The Edinburgh Postnatal Depression Scale, which I'm sure many of you have heard of it and are probably using it in your practice. It's 10 items. The mothers get a score between 0 and 30. If you're using community-based types of screening, you want to use a cutoff score greater than 9. So if a mother has a score 10 or more, then these are mothers that you would want to follow. If a mother has a score greater than 12, then that's suggestive of probable postpartum depression. It's internationally used and recognized. So if we all use the Edinburgh Postnatal Depression Scale, and you can use it, by the way, antenatally, and there's beginning research, there's 4 studies suggesting that we can use this with fathers as well. I'm not sure if it's the best one to use with fathers. We're using this in IMPACT, but we're also using male depression screening scale as well. And we'll be doing the psychometrics to see which scale is best. But right now we're going to be administering the EPDS with fathers as well. So it can be used antenatally, it can be used postnatally. It's widely available. If you just Google Edinburgh Postnatal Depression Scale, it'll pop up, and the screening component of it will come up as well. It's been translated into many different languages. And the one item that you really need to pay particular attention to is item number 10. It's about self-harm thoughts, and you should have a protocol in place in your clinical practice as to what to do if a mother scores any positive response on this. John Cox and Jenny Holden have developed questionnaires. They're the developers of the Edinburgh Postnatal Depression Scale. They've developed questions about how to ask, additional questions to ask mothers to see if this is a positive score. But just watch out for number 10. That's an important item. What is the most reliable screening process? We know that screening is not perfect, that it does lead to false positives, which means that we've identified mother as maybe experiencing postpartum depression when she doesn't have postpartum depression, and it may lead to false negatives, meaning we have said the mother doesn't experience postpartum depression, but she does experience postpartum depression. And if you're going to be screening in your clinical practice, then what you for sure want to do is make sure that you have more false positives than you do false negatives. False negatives is harm because we're missing depressed mothers. False negatives we can deal with because that means we've identified someone, and what we can do is we can track them to see if indeed they are a true case. A single screen does lead to a high false positive rate. And so what we are recommending is a 2-phase screening process. You've probably heard of this before, where we screen the mothers, and the initial screen can be face-to-face. And then what we do is we screen the mother a second time. There's no particular time frame when to do that second screen, but I recommend around 2 weeks later, just to see, because for DSM, for the mother to be diagnosed with clinical depression, she has to have that symptomatology almost every day for 2 weeks in a row. Okay, that's how you diagnose it. They have to either be sad and crying almost every day for 2 weeks, or they have to not enjoy what they usually enjoy every day for 2 weeks. They have to be positive on one of those 2 items, and then they have to have other symptomatology, up to 4 different types of symptoms, to have a clinical diagnosis of depression. And so I recommend, if you are to do a 2-phase screening, which results in the most accurate assessment, then to screen the second time in 2 weeks' time. I've clearly shown that we can screen over the telephone, so you could do that second screen over the telephone. And I've clearly shown that we can do web-based screening as well. For any of you that have participated in my postpartum depression prevention trial, which I'll talk about, we did 21,000 screens with the Edinburgh Postnatal Depression Scale over the phone, or over the web. So we can do the face-to-face, but we can also incorporate technology as we do a second screen to make it more clinically feasible. What's really important is that we ask whether screening improves clinical outcomes. So if we screen a mother, is she more likely to receive treatment? Or if we screen mothers, is she more likely to not be clinically depressed at, say, 4 months postpartum than mothers who were not screened? This is a really important clinical question, because if we can't say yes to either one of these questions, then what's the purpose of screening? Because we're not changing the clinical outcomes and the trajectories. So research clearly suggests that screening alone is insufficient to improve clinical outcomes, and that the U.S. Preventative Task Force recommends screening adults for depression in clinical practice. You must have systems in place. First of all, you must have an accurate diagnosis. We do have that with the Edinburgh Postnatal Depression Scale. It's a widely used screening tool, as we've discussed. You need to have effective treatment. We know that effective treatment for postpartum depression exists, but you need to have access to that effective treatment, and you need to have follow-up. It's insufficient to refer a mother to a service and not follow up that she's actually gone to that service to receive the treatment, because less than 30% of mothers will actually initiate that service. Less than 30%. So we need the follow-up. And it's only when we have these three components in place that we improve clinical outcomes. So this must be part of what we call a care pathway.